You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 2nd, 2023. Our topic today, very early onset inflammatory bowel disease. Our presenter is Dr. Kathleen Sullivan. She's the chief of the Division of Allergy Immunology at Children's Hospital of Philadelphia in Philadelphia, Pennsylvania.
All right. Well, first of all, thank you for having me. This is one of my favorite topics. And sorry, I had some laryngitis, so I might not have the strongest voice today. So this is one of my favorite topics. And I have to say, I never in a gazillion years thought that I would like any GI topic whatsoever. I run from the dirty diapers and I'm not really into the Bristol stool score. And so it's quite a surprise that I landed in this clinic at all, much less that I've enjoyed it. So let me explain sort of how I come at this. And at the end, I'm going to have some pearls. You do have to sort of wait through 45 minutes of dialogue to get to the practical tips. But I think the practical tips will help you because I guarantee you're going to get consults. All right, this is what I'm going to cover. I'm just going to remind everyone what it is. I want to lean hard on genetics because that's really our primary method of diagnosis. Talk a little bit, I know this is an allergy immunology group, so I'm going to say a little bit about known inborn errors of immunity and IBD or enteropathy, and then I'll spend maybe the last 1/3 on VEO IBD. So we are going to cover a lot of ground. Not all of it is going to be instantaneously useful to you, but embedded in this, I promise, are some bits and pieces that they're useful to me. I hope they're useful to you. All right, so this is the group that I work with. It's a pretty big group, and it's both research and clinical care of kids with very early onset IBD. And I'll take this moment to say the definition of very early onset IBD is onset less than 6 years of age. And the idea behind this large group is that we really provide wraparound support. So unlike some research programs, we take care of nutrition, we take care of diagnosis, management, there's psychological well-being, there's a psychologist in here, and there's a research program that's attached to this so that we can do even better with next year's patients. So that's the vision behind this. So let me talk about IBD in the general population, which is probably not where you thought this was going to go. But let's just start there because what I'm going to share with you is that very early onset IBD is just kind of a seamless trajectory. It's a seamless spectrum, and very early onset IBD is one end of that. So it helps to step back, I think, for a minute and just talk about IBD in general. So the first thing to know is that we have a lot more IBD in the US and North America than almost any other place. So if you don't know this series of papers, I highly recommend them to you. It's a series of papers on the worldwide burden of disease. So there's asthma, there's food allergy, this is the one on IBD, and they look at burden in a variety of different ways. One is prevalence and incidence, and then they look at economic burden as well as mortality. They're actually excellent papers that use sort of a set statistical approach across a range of diseases. So here is how you look at it. On the On the x-axis here is the sociodemographic index. It's basically like the gross national product, so it's a sign of wealth of the region that they're studying. This S-shaped curve up here is North America. And on the y-axis is the age standardized prevalence. So what you can see is North America is literally head and shoulders more IBD than any other region. And this has to do with industrialization and probably diet. You can see for some countries, they're way down here at the bottom. Why is this relevant? So amongst the kids with very early onset IBD, and the whole reason I'm giving this talk, there's a subset who have inborn errors of immunity. That subset is much bigger for these groups down here in, say, Africa and some of the poorer parts of Asia compared to North America. So North America, you're going to hear from me, it's about 10 to 20%, depending on some of the other characteristics. But in some parts of the Middle East, some parts of Africa where industrialization has not yet taken place, the percentage of very early onset cases that are inborn errors of immunity can be as high as 50%. So really very, very different here in North America. Now, it had been known, this is actually a Canadian study, but it had been known that among countries that are industrializing, so countries that are sort of on the path, that their frequency of IBD, as well as a range of other conditions like allergies, goes up. So the higher the rate of industrialization, the higher the prevalence of a range of autoimmune conditions and atopic conditions. But among countries that have been fully industrialized for a decade, you sort of cap out at a certain point. But what happens at that point is the age of onset gets younger and younger, and this is the paper that characterized that. So in this paper in Canada, among kids less than 5, so they were using a different definition, there was a 7.2% increase, even though the overall prevalence did not change. So the age of onset gets younger in the countries that are already industrialized. Now, what's this all about? Probably change in the microbiome, increasing use of antibiotics. There's actually data on both of these. I personally think that a lot of it has to do with the westernized diet. So there's quite a few studies now looking at emulsifiers, surfactants, detergents. These all change the intestinal permeability and allow food antigens to percolate, which probably increases food allergies, but also allows bacteria to percolate through setting up IBD. So these westernized diets we know are unhealthy. There's also the sugar and fat component, which we know increases inflammation. So you can pick which of those you think is the most evil, but I think it's probably a mix of all of those. And there, as I said, there's data to support all of them. Well, all right. So here I am as an immunologist talking about very early onset IBD. Why am I involved? So let's just talk about IBD in inborn errors of immunity, because that's where I started. So you probably know these papers. These are the IUIS papers that sort of classify the new genes and tabulate the different types of inborn errors of immunity. Right now, we're at slightly over 500 genes. You may know that this IUIS group partitions both genetic conditions as well as non-genetic conditions into these different categories. There's also a phenotypical classification that I think is more the way that we think. But anyway, I'm just going to show you that IBD crosses all of these categories except complement. So in this figure, I've tried to show that IBD is not found in one of these categories, and that's a problem for us, right? We know how to screen for antibody disorders. We know how to screen for T-cell disorders. We are pretty terrible at screening for innate immune deficiencies, I'm here to tell you. And I work on the immune dysregulation team here at CHOP. We are also not very good at screening for immune dysregulation. So it's important to recognize that IBD crosses all of these groups, with the exception of complement. One complement disorder can cause protein-losing enteropathy, but that's not frequently confused with IBD. Now, as I said, if you take a step back and think about inborn errors of immunity, there's a lot of autoimmune disease in inborn errors of immunity. So this is from a paper in 2014, just kind of tabulating the rate of autoimmunity across all of these different conditions. You can see it's pretty high, ranges from 0.5% up to 11%, and that's probably an underestimate. This comes from USIDNet, and at a time when we probably didn't tabulate the autoimmunity as accurately as we do now. This was also borne out in this French study. So this is from the French Registry for Immune Deficiencies. And what they did, I think, was actually really valuable. So they looked at the prevalence of different types of autoimmunity. You can see them listed over here on the left. In their cohort with inborn errors of immunity, they fished out some prevalence numbers for the general population, and then they calculated a relative risk. And so the usefulness of this is that autoimmune cytopenias are very strongly associated with inborn errors of immunity. And we all know that. The hematologists know that. So that's not a surprise. But look at what comes in number 2. It's inflammatory bowel disease. The relative risk of 43 in adults and 80 in kids, higher than anything except autoimmune cytopenias. So definitely there's a relationship between risk for inflammatory bowel disease and inborn errors of immunity. This now is looking at a cohort with diagnosed inborn errors of immunity. So let me just take a couple of examples here, because I think these are scenarios that you're more likely to bump into maybe than the very early onset IBD. So just to take a pretty broad lens at this topic. So let's talk about the GI disease and common variable. So this is particularly problematic, less so today than 10 years ago, and I'll explain why in a minute, but it definitely causes misery among the affected patients. So what's interesting, I think, is that the range of prevalence is 3 to 15%. And so it's been suggested that there's a geographic effect, just as I showed you 10 slides ago, is true for IBD, that there's a geographic effect related to westernization. So if you look at the GI disease in common variable, a fraction of it is nodular lymphoid hyperplasia, those tiny little lymph nodes that line the GI tract. Some people think that these are asymptomatic and that they're incidental findings. I actually think they cause symptoms. I think they cause traction and some motility issues. And if I have a patient who's symptomatic and I see this, I will treat it with rituximab. Only a 4% rate of IBD, so in this whole panoply of GI disease, IBD is actually not the most common. We do see some granulomas in the GI tract that isn't necessarily looking like IBD. And then there's this 1 to 2% with enteropathy. Now, 1 to 2% is not a very big number, but these folks are very problematic. And if you've ever had one of these cases in clinic, you know, first of all, the patients are miserable. They can't work. They can't go to the grocery store. They can't participate in life. This is the single biggest hit to quality of life in all of the inborn errors of immunity. Now, in older literature, you will sometimes see this enteropathy referred to as non-gluten responsive celiac. And the reason is that under the microscope, it looks just like celiac disease, but you withhold gluten and they don't get better. So they have high numbers of intraepithelial lymphocytes, which is one of the characteristics of celiac disease. And they have villus blunting, again, a really prime characteristic of celiac disease. But they don't respond to gluten withdrawal. And this is, I think, important for us to talk to our GI colleagues about. So I'm going to focus on the enteropathy. So it confers a poor prognosis. Now, I'm not sure that's true today, but it definitely confers a poor quality of life. So what are some basics that you don't need any special knowledge to do? So you have to optimize nutrition, and this means you have to purposefully check vitamins and micronutrients, not just think, oh, if they're eating a varied diet, they are doing okay. You have to purposely check particularly the fat-soluble vitamins, and then micronutrients like zinc and selenium. You want to rule out infection, right? This could be cryptosporidia, could be giardia, and this often requires a biopsy. And then ensure that the immunoglobulin dose is adequate, because particularly for the small bowel enteropathy, they will lose protein, and so it may be that you're giving a perfectly reasonable amount on a monthly basis, but their trough level is still 300 or 400. So why do I say the prognosis is probably changing? Well, 2 treatments have really transformed the lives, sirolimus and abatacept. Now, everyone's got some story of a patient who doesn't respond to abatacept, but in general, they will respond to, I usually start with sirolimus, pretty rapid onset, you don't need any special approval usually, and then go to abatacept if I don't get traction or I don't get enough traction. If you see a lot of neutrophils and it actually looks a lot more like IBD, you can try TNF inhibitors. And then for nodular lymphoid hyperplasia, as I said, I use rituximab. So let me segue to another scenario that you've probably seen, and that's inflammatory bowel disease in XLA. So the rate of IBD is in the range of 5%, so not super high. But again, these folks can really be impacted in terms of school or work. In my experience, it responds well to prednisone and TNF inhibitors. Now, virtually every time I give this talk, someone says, oh, I've got someone who didn't respond at all. I agree, it happens, but this is where I would start, because at least in my hands, it works for well over 3/4. Some cases actually respond to antibiotics. And if you don't know, antibiotics is a time-tested therapy for IBD in general. Whether it works better in XLA and other inborn errors of immunity than the general population, I don't know. But I've had 2 pretty durable remissions with antibiotic therapy and nothing else. So I think it's worth a try. And then here again, be sure to rule out infection, Giardia, Cryptosporidia, and norovirus. And then the last scenario I want to talk about is chronic granulomatous disease. So most patients with chronic granulomatous disease are getting transplanted early in life, thankfully. Transplant does actually completely eradicate IBD. So if you have a patient with pre-existing IBD, you don't even have to get it into remission. If you just put them on the transplant protocol and start conditioning, their IBD will melt away. If you have a patient who really doesn't want to go to transplant, maybe an older patient, maybe there's reasons they don't want to go, maybe they don't have a match. I like steroids and anakinra. NIH likes steroids plus ustekinumab. I use ustekinumab and CGD very infrequently. There are some case reports of vedolizumab working, which doesn't entirely make sense to me. But again, I'm just sharing with you the data. I always try steroids and anakinra, but I'm almost always taking my patient to transplant. And then just as a reminder, don't use TNF inhibitors because the risk of fungal infections is very high among CGD patients on TNF inhibitors. So here are my tips for the classic inborn errors of immunity who have IBD or enteropathy, some GI inflammation. Check and double check for infection, even to the point of getting a biopsy. And why do I say this? I've had multiple patients with Giardia and Cryptosporidia that were antigen negative by PCR or ELISA, but we found it on biopsy. So almost all these patients are going to go to biopsy anyway. You just want to highlight to the pathologist that they should look for infection. I'm going to talk a lot about genetics today. So particularly in common variable, knowing the gene is your ticket to optimize therapy. And I'll talk more about that. If you don't have a gene, then use the pathology to guide therapy. And I'm going to come back to this. And then weirdly, just this little tidbit, if you find norovirus in a patient with common variable, don't let that hold you back from immune modulation. Often the norovirus will abate with immune modulation. So we used to kind of fiddle around with nitazoxanide and oral immunoglobulin and all of these approaches to diminish the norovirus. But honestly, they often respond if you give them a beta-sept, which I know feels wrong, but they do. All right. So let me transition now and talk about VEO IBD. So now we're going to sort of come at it the other way. So I've been talking about folks who have a known diagnosis of an inborn error of immunity, and they also happen to have enteropathy or IBD. Now I'm going to come at the question that I most often get in very early onset IBD. We've got a kid with very early onset IBD. Could it be an inborn error of immunity? And why is that a critical question? Many of the folks with inborn errors of immunity that present in VEO IBD clinic are going to go down a different therapeutic path. Many of them will get a transplant, and even for those who don't, they may get treated with different immune modulation than you would normally pick. So there really is a compelling reason to try and establish a diagnosis. So I showed you the whole VEO IBD group. I want to call out a special acknowledgement to Judith Kelson, who's really taught me everything I know. And so it's really Judith that is responsible for me being able to give this talk at all. I certainly could not have given this talk when I started in clinic. So let me just tell you about the CHOP cohort, because this is the foundation for my experience, but also some of our data. So I am going to show you some data, although I'm going to try and really root it in practicalities. So at various points, you're going to see me compare an older onset cohort with a younger onset cohort. We actually have over 1,000 patients, but these are pretty carefully curated to make sure we have all of the data. You can see strongly skewed towards Crohn's disease, which is true for the older cohort, some ulcerative colitis, and then we use IBD undifferentiated quite a bit. So what does that mean? It doesn't mean they don't have IBD. It means they have IBD in the colon. We can't really tell if it's ulcerative colitis or Crohn's. We don't want to label someone too early and then have to change the diagnosis later. So we favor this more than some other centers do. So if you have been involved in your center and this number seems high, that's why we know we skew a little bit towards that. So I'm going to share with you some bits of this data just to make a couple of points. So the treatment failure rate is very high. So the blue bars here and here are the failures. So the blue bars are the early onset kids, and the yellow bars are onset over 10 years. You can see the failure rate is over 50% for TNF inhibitors for any immune modulation. So that's why this is a tough group, because they don't respond to the typical treatments. Because of that, they go to the OR more frequently. So here's a diversion where you basically don't remove anything. You're just trying to deburden the colon from all of the bacterial stimulation. So about a 12% rate for the very early onset kids, 1% for the older onset. A true colectomy where the colon is removed, about 7% versus about 1.5% in the older kids. So surgical intervention is much higher. And I've said it already, but these kids are really tough to manage. They burn through their biologics. They really are I spend much more time managing the non-monogenic cases than the monogenic cases. So let's just take a minute to talk about pathology here. So this is a crypt cut in cross section. Hopefully you can see my laser pointer. You'll see these white areas that look a little clear. These are apoptotic crypt cells. Now, apoptotic crypt cells are seen in IBD, but when you see a boatload of them like this, the pathologist is going to think that this is graft versus host. This is pretty typical for graft versus host disease. And so you may get a call from the pathologist saying, you didn't tell me this was a bone marrow transplant case. Why not? But it's just characteristic of the severity of the disease. It's the high level of cytokines that are killing off these crypt cells. If you are very sharp-eyed, you will notice some fuchsia-colored speckles throughout the interstitium, also in the crypt itself. This eosinophilia sometimes leads patients to be diagnosed with food protein-induced enterocolitis or an EGID variant, but it's really not. Eosinophils love to show up to a party, and particularly early in IBD, you get a lot of eosinophils, so don't be fooled by that. The pathologist may try and take you down a different path, but the eosinophils are not a sign of something else. Now, I've already talked about genetics a little bit. I'm going to say a few more words here because we use genetics a lot. So this is a concept I hope to convey. I hope my little simple-minded diagram here works. So the idea, each of these buckets has some microbiome risk, some environment risk, and some genetic risk. Hopefully, most of us are in this first bucket. So this red line is the threshold. If you cross the threshold, you have IBD. If you don't cross the threshold, you don't. So hopefully most of us are in this first bucket. Maybe our diet's not so fabulous. Maybe we've had some antibiotics, and we have a couple of genetic risk factors. For the kids who've got monogenic IBD, that gene is driving the disease full steam ahead, but there's still a little bit of microbiome that's contributing. And we know from knockout mice that most of the monogenic effects won't manifest in germ-free mice. And so we do think that in humans, there is a component of the microbiome. And most kids don't present on day one of life. Their symptoms manifest in months or years, and that's because we presume of the environment and the microbiome. We have one case that's digenic, super hard to show. We don't even know how to approach trigenic, but actually there's a lot of data on polygenic because this is the standard adult onset IBD. Lots of genetic risk factors, each of which is 1.4, 1.5 relative risk. Big effect from the environment and the microbiome, and that's what pushes people over the edge. So I'd like to convey to you that it's part of a spectrum. This monogenic IBD is not a different thing. I hear people sometimes saying it's a different thing. I personally don't think it is. So if we look at the genes that have been identified in genome-wide association studies, I've listed them here. This is from the UK consortium. You can kind of partition them into innate immunity, adaptive immunity in red, and barrier function in green. Not much difference between Crohn's and ulcerative colitis conceptually, and these genes that are sort of tinted, they are the ones that are shared between Crohn's and ulcerative colitis. So a lot of sharing between them, and certainly conceptually very similar pathways, even if the genes aren't one-to-one matching up. Here's our monogenic causes of VEO IBD. So it's about 10% overall. It was 20% as recently as 5 years ago. It's 20% currently for infantile onset, so onset in the first year of life. And I've kind of divvied these up into different groups here. These were the genes we thought we would see. We built a gene panel to look for these. There are some known associations, and then we got some genes that we weren't expecting, but are known inborn errors of immunity. I don't want to neglect the chromosome defects. So Turner's, trisomy 21 and 22q deletion all have enrichment of IBD. And then in collaboration with other groups, we identified 2 new genes, IL-2RB with Elena Shea and STXBP3 with Jody Wahed. So why do I show this to you? First of all, just to prove we've been busy, we have been busy, but also to make a point that you would be hard pressed to pick a panel unless you use the Invitae PID panel, which is 400, I think it's 411 genes now. You'd be hard pressed to kind of assemble a panel because there are genes that come up multiple times. So this is X-linked CGD. This is the IL-10 receptor. There are genes that come up multiple times. Look at the ones that are sort of one and done. So really hard to come up with a panel because of the diversity of genes that pop out of our cohort. Now I've circled these because these are sort of the high likelihood ones. You can see XIAP, chronic granulomatous disease, IL-10 receptor. We seem to have a lot of SCIB2L. This is the trichohepatoenteric disease. So we seem to have a lot of that. So these would be the biggies, but again, look at how much you're leaving out by focusing on those. Now here, I have chosen to put red boxes around the ones for which you could reasonably screen for using flow cytometry. So chronic granulomatous disease, we are pretty good at making that diagnosis by flow cytometry. And here in the middle, we have some with low T cells, low B cells for BOC2, DOC8 low T cells, TTC7A low T cells, RAG1, BNB low T cells, ZBTB24, IgA deficient. So there are some genes where you might be able to get a hint doing standard immunologic screening. But look at how paltry that is. That is not your best approach. Your best approach is genetics. So if I take our genes that we have found in our cohort and divvy them up the same way I did with the GWAS studies, you can see, again, barrier function, innate, lymphocyte. Conceptually, it's the same. So again, I just want to make the point that this is part of a spectrum from polygenic to monogenic. We're just not smart enough to find the digenic and the trigenic. They're just too hard for the computer to find. So again, just making the point that this is all part of the same spectrum, which I will come back to. So monogenic, one gene drives disease. We know there's lots of examples of this: sickle cell, cystic fibrosis, polygenic. Examples are obesity, allergies, diabetes. So we see this play out in our clinics all the darn time. So hopefully this isn't a completely new concept to you. Other people look at this. This happens to be for cardiac anomalies and cardiomyopathies, just making the point that in monogenic, it's one variant that's really driving it home. In polygenic, it's a lot, and then this big box in the middle that we don't really know much about. All right, so hopefully I've convinced you that we're talking about a spectrum, all of which have as the end manifestation IBD. And the monogenic cases have an amplified gene effect. How do we find those cases? I don't mean to be smart alecky here. We do sequencing, but I want to say it because I find so often people say, well, we did immunoglobulins and titers. I'm like, oh, that's not really going to take you very far. You really need sequencing. So are there any screening tests to stratify patients? When I started this, I thought for sure I would find screening tests, but no. Sadly, no. So this is a paper we published looking at flow cytometry. You will see that there's 2 cases with low T cells here among the monogenic cases. These have TTC7A deficiency, and because they had multiple intestinal atresia, they were not mysterious. We already knew the diagnosis. So you can see, by and large, not much difference in the T cells, the total Ts, the CD4s, or the CD8s. We did a very extensive flow cytometry panel, more than what you could get in the clinical lab, thinking, well, we just need fancier flow. So this is fancier flow. And if you are sharp-eyed, you might see that the edges have a distinct pattern. And we thought, aha, they are enriched for inborn errors of immunity, and that's actually not true. So it's true that we found a few, but actually there's no statistical enrichment, and we find monogenic cases in the middle here. So why is that? I mean, we're immunologists, right? We look at T cells, we count B cells, we like doing dihydrorhotamines. Why is it? Well, here is the problem. The flow cytometry is very impacted by disease, by medications, and nutrition. So a lot of these kids, when we meet them, they are undernourished, and we know that malnutrition is a major modifier of immune function. But the medications, particularly steroids, really alter the flow, and then the disease itself. So sometimes I get emails going, oh, these NK cells are really low. Well, NK cells fold up shop and go away if there's acute inflammation. So the disease itself can drive some flow cytometric changes, which means that your general IBD population and your monogenic population often look quite similar. Well, what about family history? So flow, not that helpful. What about family history? Precisely because we are practicing in the US, there is a ton of IBD out there. So we almost always get a family history of IBD. I would say it's only about 10 or 15% where we get no family history of IBD. And it is the super high rate of IBD in the US that kind of dilutes out the youthfulness of family history. I'm a big fan in general of getting a family history, but in this setting, it's not very helpful unless I get a multiplex kindred, multiple affected siblings. Then it might be helpful, but not even then for sure. Are there any clues? So we did machine learning on our entire cohort with all of the variables that we collect. We collect a lot of clinical variables. Were there any statistical associations with monogenic cases? Yes. Panenteric disease and short stature. I'm sorry to say that you can't use these as screens though. So while there was a statistical association, it's not a tight enough association that you could in any way use this to screen. I'm sorry. I wish the answer was different. So I've talked a lot about genes. Let me explain why I am so avid about getting genetics. I mean, I like genetics, sure, but I want to convince you that knowing the gene can really help you therapeutically. So I've listed some of our more common diagnoses here at the top that we treat with transplant, and we have a paper coming out soon. The success rate is huge. Actually, right now, the success rate is 100%. I'm sure that can't last, but right now, the success rate is 100%. For dyskeratosis congenita, which has a really miserable enteropathy, IBD, the treatment of choice is danazol. I have to say it has not been effective for IBD in my hands. Sorry about that. For CTLA4, LRBA, PIK3CD, we always try sirolimus and abatacept. I have one kiddo with CTLA4 who's not doing great. I mean, he's better on abatacept, but he's not really where I'd like him. And he's maybe our first CTLA4 that we're going to take to transplant. CARD8, the recipe is IL-1 inhibition, L4, IL-1 inhibition, and LRC4, IL-18 binding protein, which is available on a compassionate use under the name of Tadakinib. Also tells you what not to use. So don't use TNF inhibitors for CGD. Trichohepatoenteric syndrome and multiple intestinal atresia, we don't usually transplant. Actually, we don't transplant trichohepatoenteric syndrome. We've transplanted one case of TTC7A. I don't know that we did him any favors. It's thought that there's a thymic defect that limits the efficacy of transplant here. So again, knowing the gene is really your ticket to optimizing therapy. It's not just stamp collecting. These genes really impact management. What are our transplant outcomes? So mostly good. As I said, this TTC7A and STXBP3, they are improved, but they don't have normal stools. So I think we helped the patient with TTC7A, but the patient does still have some diarrhea. In LRC4, they do great on Tadakinib. I don't know if we can get it forever for them, but certainly they're doing very well. CARD8 doing great on anakinra, as is L4, and LRBA on abatacept did pretty well. So this is really what we're all trying to do, right? We're trying to really maximize personalized medicine so that when we step into the room, we know what's going to work and we can make a recommendation to our patient. Now, as I said, when I started in this clinic, my vision was I would take care of the kids with monogenic disease. And I do, but they turn out to be easy. Many of them go to transplant. The rest are on abatacept or anakinra. They do great. So I actually spend more time on the non-monogenic cases. That probably will not be your experience, I'm guessing. I was part of this clinic at the outset, so I've committed to taking care of all comers, but you might carve out a more narrow vision for yourself if you're called to do consults. All right, so here's my practical tips. So let's say you don't have a G. So pay attention to the type of GI inflammation, and this might involve going to pathology and reviewing it with the pathologist. Personally, I love that part, but I know many people don't. So what are you looking for? You're looking for, is this small bowel? Is this colon? What's the inflammatory cell type? Is it all neutrophils, all lymphocytes? Do they have other locations of inflammation? Do they have arthritis? Do they have lung disease? Do they have something else going on? So I'll just tell you, neutrophilic inflammation more often responds to TNF inhibitors. Lymphocytic inflammation, more likely to respond to sirolimus, abatacept, and vedolizumab. These are not hard and fast rules. I'm just telling you what we would pick first. Do the monogenic cases help us with the polygenic cases? Yeah, I think so. So we tried to extend on a phenotype basis what we'd learned from the monogenic cases. So I'll just share with you two quick snapshots here. So we took a smallish subset of our cohort with very early onset IBD who had persistent fevers, leukocytosis. We do a cytokine panel. They had at least 2 cytokines that were elevated, and they were very sick. These were for the most part infants. They had malnutrition. 3 of them had arthritis. And what we used was ruxolitinib, one of the JAK inhibitors that's approved for IBD. We saw efficacy within 1 week. These were all hospitalized patients, as you might guess. Their SED rate went from 77 to 25 by 6 months. They gained weight, and their arthritis and fevers resolved. So why did we do that? Well, we had used ruxolitinib in a subset of patients with monogenic arthritis that had an interferonopathy and arthritis, and it worked really well. So these were sort of phenotypically related. That's why we tried ruxolitinib. Same idea here, another small cohort of 18 kids with severe disease, fevers, leukocytosis, high SED rate, oral ulcers was the anchor here because this made us think of PFAPA, familial Mediterranean fever. So we sort of went down the IL-1 path because it felt like that. But I'd really like you to pay attention to these failed treatments. So this is so often the case. These poor kids just burn through biologics. They sort of miserably cycle from one failed treatment to another. Initially they have hope. Oh, the next one will do the trick. Boy, these kids, you have to be prepared that it may take you a little empiric trial and error to get them to a better place. These particular 18 did very well on their anakinra, and we do love anakinra, or once we get traction, we transition them to canakinumab. All right, so if you don't have a gene, let's just go through pathology one more time. Classic neutrophil abscesses in the colon. We would start with a TNF inhibitor plus or minus methotrexate. We like ustekinumab, we like vedolizumab. Those would be secondary for us. Occasionally we use steroids acutely. They're not so great for healing. So we don't use a lot of steroids acutely. I know some centers do. But don't forget nutritional therapy. So we work with an amazing nutritionist. And I don't know if you know this, but defined enteral therapy has a success rate as high as steroids. So if it's an infant or a toddler, they're fine with formula. They don't miss hamburgers and pizza. A little trickier for the older kids, but sometimes they're miserable enough that they're fine with that. So don't forget nutritional therapy. And then this triple antibiotic regimen that I alluded to before. Again, these are probably not going to be your long-term answers, but often they're a bridge until you get something else working. And I'll just point out that vedolizumab, when you start it, it takes 3 months to work. So particularly when we start people on Veto, we often have to bridge them with something else. Different kettle of fish if you're talking small bowel enteropathy. So this is almost always T-cell directed. Here we would start sirolimus, we would go to abatacept, we like JAK inhibitors. We do use tacrolimus in both cases, but boy, I always feel crappy about starting someone on tacrolimus, and I know they're going to be on it for decades. All right, for infants, special circumstance here. IL-1 inhibitors, JAK inhibitors, we tend to favor. Think about transplant even if you don't have a gene, because their lifelong likelihood of achieving durable remission is not very good. Where is all this going? Well, monogenic cases, hopefully I've convinced you that we can stratify for therapy using genetics. But again, monogenic causality is just the tip of the iceberg. Can we harness phenotype, transcriptome, self-phenotyping to stratify for therapy in lieu of genes? Maybe. I showed you some of the data on phenotype stratification. And then I'll just leave you. I think immunology contributes to management and antimicrobial prophylaxis decisions. So I think we do have a role to play even in the polygenic cases, but I know not every center takes that on. So here, I'll just sum up with some big messages for you. VEO-IBD can be a severe disease. So not everyone, I don't want to leave you feeling like every case is a tragedy. That's not true. But I would say well over half have quite severe disease with significant burden, and they have more years of disease, meaning it's going to be harder for us to find a durable therapy. Hope you got the message about genetic testing. Monogenic causality is highest in infants. Panenteric disease and short stature are clues, but again, you can't really use those as your anchors for deciding when to send genetics. I think we're poised to exploit phenotype and other omics to stratify patients for treatment. We have a single cell program going on now. We hope that that will teach us which therapies are going to work, but it's been a longer road than we would have guessed. Let me just acknowledge people who did the work. Kelly Maurer did all of that flow cytometry that I shared with you. The genetics is a group effort, but again, I want to acknowledge Judith Kelson. Judith and I think, read all of the whole exomes that come back. Noor Dewani does the bioinformatics. And this is my lab pretending to be lupus warriors, which isn't relevant for the talk today. But if you wonder what we're doing, we were asked to make a video, and this is our punchline to the video. So I'm going to stop sharing there and just see if there are questions for me. There we go.
All right. Thank you, Dr. Sullivan. Open for questions, please.
Hi, Kate.
Hey, how are you?
Hey, good. Good to see you. And as always, just enjoyed your talk and excellent information. I actually have a ton of questions, but I'll ask one or two and then open it up for everyone else. Do you use cytokine panel, CXCL9, all those tests, and is there any value, and where do you utilize it?
I liked how you partitioned it into two questions. Do you use it and do you find value? So we use it. I cannot in good faith tell you that we find value in it.
Okay.
It's actually a rare case where we see the serum cytokines very dramatically impacted. So yes, we use it. No, I can't persuade even myself that it's of value.
Sure. You talked about the genetics, using genetics. We use quite a bit. We do struggle with insurance quite a bit with some of these cases getting exome sequenced. And so some of them we send the Invitae panel because they meet the criteria.
Yeah.
But where do you stop if the Invitae panel doesn't give you the answer? Do you push for exome or leave it and just use the pathology to help with the treatment decisions?
Yep. So I think the Invitae panel is extremely good. I think, if insurance won't pay for a whole exome, I think you've done your due diligence. How often do we find something on exome that's not? So we have we seldom use the Invitae panel, but we have a home-baked one that's pretty similar. So how often do we find something on exome that we don't find on our home-baked panel that's supposed to roughly equal the Invitae panel?
Sure.
Not very often. I would say 5 times a year. Not very often. And our clinic is huge, just to say it's 1,000 kids. So not very often do we get it from exome.
Sure. one more question. For norovirus, you did mention oral immunoglobulin use, and is there like a good resource to use for what kind of dosing you use for that? How long do you try that?
So I have to look it up every time. I'm so sorry.
Okay.
There actually is a recipe in one of the papers, which I can send you if you can find it.
Sure.
So I try it for a month. I don't know that there's anything magic about it, but I figure, if I'm going to get something out of it, I should see it by then.
Okay, sounds good. Well, thank you. I appreciate the talk and all the information.
It's so nice to see you.
All right. Thanks, Dr. Raji. All right. Any other questions from our listening audience today?
Are you getting these consults generally on the inpatient side or the outpatient side?
So fellows can talk a lot about it actually, but they get a lot of
Inpatient.
inpatient. Yeah.
Yeah, I think it's tricky because if they're sick enough to be inpatient, their flow is going to be a little on the wonky side anyway. So, yeah, they are, they're tough cases, right? The kids are super sick and you want to be helpful. Yeah, I hear you. And often the genetics takes a long time to come back. So then you've got that window where you're like,
Don't know what to do. And I see a lot of outpatient as well. So it's like a combination. Even with that, I feel like our immune workup doesn't help a lot. Sometimes it does give us a clue, which is nice. But otherwise, there are times when it's genetics for sure. So.
yeah.
I have a quick question, and you might have mentioned it already in terms of kind of like acute management and kind of more chronic evaluation of these patients. But, for patients who have like very severe symptoms, they've been hospitalized and they may be on like high dose steroids, for example, or like a chronic taper, I guess how, if we need to do the workup, we have to do that. But in the time frame may be indeterminate, but I guess, that flow may also be significantly abnormal or be influenced potentially by this high-dose steroids or chronic taper. So when do you reevaluate that? But again, I know that there's other things that we would consider too.
Oh, well, now I have to confess to you, I get a DHR and I don't get other flow. So I know that seems sacrilegious for an immunologist, right? Not getting flow, like, I need to turn in my diploma, right? But actually, that's all I get. I get a dihydrorodamine. I don't get any other flow. If I'm worried they've got protein-losing enteropathy, I might get an IgG just to see if I need to support them, not diagnostically, but just trying to protect them. And then I get genetics. And then I say, I'm here if you need me to interpret the genetics when they come back. So I don't get flow. I know that feels really wrong. It did to me. I have to say, I really struggled with that decision, but that's where I've landed. Right or wrong, that's where I've landed.
I like it.
All right. Any other questions?
I will say the super sick kids, don't be afraid to start something like tacrolimus, right? Because kids do die of this. So, they translocate bacteria because they've got so much inflammation, they get septic. Kids do die of this. So I don't love the idea of tacrolimus for a decade, but sometimes like the example that you gave on steroids, can't get off, hospitalized repeatedly. Don't be afraid to throw some tacrolimus at them. It's a big gun, but often it has efficacy pretty quickly compared to something like vedolizumab. And then once you've got them to a better place, beefed up their nutrition, then you can, add in a biologic and try and taper it off. I think sometimes we're scared of the big guns, but I'll just tell you, having done this now for 6 years, it feels terrible when someone dies. It just feels terrible. And so I'd rather be a little aggressive up front. Yes, I know there's risks with tacrolimus, but I'd rather be a little aggressive to try and get some control, because don't discount that bacterial translocation effect. They do. We've actually recovered bacteria in the blood from some of the kids with severe inflammation. It really gives you pause.
Okay, well, Dr. Sullivan, thanks for a wonderful presentation. We do appreciate that you spent your time and energy with us today. As usual, we'll have this uploaded to our YouTube channel, COLA, within a couple weeks, and be able to share the information with the rest.
cool. I can't watch myself, but that's my own particular pathology. Nikita, it's wonderful to see you. Chris, wonderful to see you. And fellows, I know it's a long road, but hang in there. It is the most fun specialty in the world. Take care.
That's great. Thank you all.